at Purdue Medical School at Indiana University, and then did her general surgery residency at Northwestern, followed by a peripheral vascular fellowship at Loyola. Dr. Shireman then joined the faculty in 1999. She is presently a professor of surgery in the Division of Vascular Surgery, and also is the Vice Dean for Clinical and Translational Research. We're transitioning to it, right?
We're transitioning to translational.
Right. And it's a pleasure to have you here this morning as you tell us about these topics. Dr. Shireman.
You turn the light off.
If you push it, if you hold it too long, it shuts it off.
Okay.
You should be armed.
Can everyone hear me? All right. Well, thanks, Dr. Serenik. I'm very happy to be here, and I also want to welcome the medical students who are interviewing for residency positions. I'm going to try to focus this talk a little bit more on junior residents and the interviewees with the idea of how our lives as physicians are going to change over time, and how my life as a physician has changed over time, and yours will change even more than mine. So I want to give you a little overview of why academic medicine is still the world's best job, and that's from Jane Rush, one of my colleagues at the University of Colorado in Denver. But it has a component of constant change. I'll tell you a little bit about my clinical life, because it's going to reflect upon your clinical life and how endovascular surgery actually became a very important component of our clinical work, which was not an important component when I was a resident. And I think I can say that when I was a resident, all the general surgeons at the time were learning how to do laparoscopic surgery. So at some points in time as a resident, I was more experienced in laparoscopic surgery than my attendings were. And those things will happen to you as well. Research, I had a lot of initial goals and unexpected turns, and yes, constant change with how funding has happened and how we do things now versus, say, 20 years ago. And then I want to talk a little bit about healthcare in South Texas, because here you have the opportunity not only to do basic science and translational science, you have health disparities, you have healthcare delivery. I think that, in a sense, for the physicians of today, the world's your oyster. And there's lots of things that you can do that perhaps I didn't even dream of doing when I was a resident. So I think there are wonderful and interesting questions for everyone to ask and answer, which is why academics is one of the best jobs in the world. So why is academics the world's best job? Well, research is fun. You get to ask questions, and you receive money to answer those questions. I mean, how great is that? I come up with a question, I write a grant, and if I'm lucky enough to get that grant funded, someone gives me over $1 million to do it. That's pretty cool. And I get to follow my interests and my passions. When you go out to industry, you don't get to follow your interests and your passions. You get to follow what they tell you your interests and passions are. And teaching is fun, and being taught is fun. I'm surrounded by eager young minds in the clinics, in the OR, in my lab. I work with junior faculty, and I get to have multiple aha moments from my students, from my residents, and a lot of times they're mine. All right? And then caring for patients is a privilege. They trust you with their innermost, darkest secrets. They believe in you, and that is a trust that we as physicians can never underestimate and never take for granted. And then we get to meet and work with the most amazing people. A lot of them are sitting in this room right now. I have colleagues across the world that I have met and have had the privilege of interacting with, and the world is becoming a much smaller place. So as an academician, I'm a vascular and endovascular surgeon. I have patient care. I train residents and medical students. With basic and translational science, I am in a lab. I do research. I have grants. And I train medical, graduate, and postdoctoral students. And then as the Vice Dean of Clinical and Translational Research for the School of Medicine, I have a whole broad view of research in toto for the school. And that has a really broad gamut from everywhere from holding a pipette to lobbying our elected officials about healthcare policy and how we can change that to improve the care of our patients. So why medicine? And that's a question I think each and every one of you had to ask yourself. Why do you want to go into medicine? And you had to come up with a pretty good answer to get into medical school, right? So I was fascinated by science, and I had a huge admiration for the doctors that took care of my family. And I'm the only doctor in my family, so I really didn't have a model to follow. And I can remember seeing my first surgery, and I just couldn't blink. It was the most amazing thing. And I went to Purdue University for undergrad, and a very important part for the junior residents and for actually the junior faculty and for everybody is the importance of mentorship. My first mentor was a man by the name of John Story in the Department of Nutrition at Purdue University. And he taught me about science, he taught me how to ask questions, and he had a very big influence on my career. And I still talk to Dr. Story, and I meet with him whenever we're at meetings such as experimental biology. But his example inspired me, and that will happen to you through your career, that people that you meet will inspire you and make you better. So I then went to Indiana University School of Medicine, and then, of course, the people here who are looking for a residency, you're kind of wondering, what's my path? How will this all play out for me? How will choosing my residency set me up for the next stage of my career? Well, I went to general surgery at Northwestern, and I spent 2 years in the lab studying abdominal aortic aneurysms. Then I went to vascular surgery at Loyola and did 1 more year in the lab. And once again, I met another amazing individual, and that's Howard Chrysler. Howard Chrysler is a vascular surgeon at Loyola who has a VA appointment, he has a VA Merit Review grant, and an NIH R01 grant. And I patterned my career off of Howard Chrysler, and that's one of the reasons I chose to come here, because there was a VA. And that opened up a whole other area, a whole funding stream for my research. And so after finishing Loyola, I came here in 1999. While all of that was going on, while I was working very hard in the lab, while I was working very hard to learn how to be a surgeon, Julio Palmas here in San Antonio is a professor in radiology, and he invented balloon expandable stents, the Palmas stent. And it was patented in 1988, and is recognized as being one of the top 10 patents that changed the world. And it did change the world, because it changed the way we treat patients with vascular disease. Also, because of the stent, another man named Juan Parodi in Buenos Aires did the first endovascular stent graft. It was a homemade device for a patient who was too sick to undergo an open repair but had a symptomatic aneurysm. And so he did that in Buenos Aires, and in 1992, he put the first stent graft in the United States at Montefiore Medical Center in New York. Today, it is a routine procedure. So what I'm telling you is that I came to San Antonio as a very well-trained open vascular surgeon, and I had a few endovascular skills, but the vast majority of people from my era who came out of their fellowships didn't really know how to do endovascular. And I learned how to do endovascular here. This is what's going to happen in your career. What you learn now will be very valuable, but you will continue to learn throughout your career, and the procedures that you do will change. So learn to embrace the constant change and not fear it. So why vascular? Because blood vessels are about the most fascinating thing I can think of. They go everywhere, and they do everything. So I learned my endovascular techniques in San Antonio, and why do I perform research? Well, I hate amputations. I hate them. I hate telling the patient, there's nothing more I can do for you, I have to cut your leg off. I hate telling the family that, well, your loved one is going to have a difficult time. I don't know if he'll ever walk again. I don't know if he'll be able to walk with a prosthesis. I don't know if his cardiovascular status will handle it. He may be bedbound the rest of his life, or her life. I'm at the VA, so it's mostly he's. So I hate amputations, and despite doing all we can, and my partners do all we can, we still cut way too many legs off, especially here in San Antonio with our Hispanic diabetic population. So that is the big motivation for me to go into the lab. because we just don't do a very good job despite our best efforts. And I think when you talk to most clinicians who do research, that is what you will find. There is some problem that vexes them in clinic, that no matter how hard they try, no matter what we study, no matter what way we try to do it differently, we fail. And the only way to get past that is to go in and learn to do something differently, to really change the paradigm, like the stent that Julio Palmas invented, like the EVAR, the endovascular stent graft that Juan Parodi invented. It is to change the paradigm of how we treat our patients. And it's my firm belief that as clinicians, it is our goal to take the knowledge that we currently hold so dear and work so hard to learn to make it obsolete. To make it obsolete because the care paradigms that we now have are so much better than we currently have, that if we can make our current skill set obsolete, we will do a great service for our patients and our trainees. So what is our lab study? Well, I started on a perfectly reasonable topic for a vascular surgeon, which was collateral artery formation. How do blood vessels form around blocked arteries? And that led to something that wasn't so typical for vascular surgeons to study at the time, which was skeletal muscle regeneration and angiogenesis, which is different from collateral artery formation. Angiogenesis is capillaries forming, so single cell blood vessels. And then we got very interested in white blood cells, and especially the macrophage, and how macrophages actually interact with all of these different components. So this is a picture of a patient, of a CT with 3D reconstruction, and you can see that the abdominal aorta is occluded, and you see these very large collateral vessels. Well, this really happens. Happens in all of our patients. When the blood vessel occludes, there's collaterals that form. And these collaterals are actually very well described. And it happens to a variable degree. So, in other words, there are some patients who, when they have a superficial femoral artery occlusion, they're utterly and totally asymptomatic. Some people have claudication, which means that after they walk a certain distance, they get pain in their calves because they can't get enough blood flow to their muscle that's now working and has a greater blood flow demand. And other people have limb-threatening ischemia. And that has a lot of different variation as to genetically, why do people form collateral arteries? What was the timing of the blockage or the occlusion of the superficial femoral artery? There's a lot of factors that go into that. But this is a very important part. And the thing that actually fascinated me is not why collaterals formed, but why did they stop forming when the patient still was ischemic? And this actually comes out of a book chapter that Carlo Martinez and I wrote. So Carlo is present. He looks very serious here, doesn't he? Always, yes. Carlo right there. He's a very serious young man. So, collateral artery formation. This is a mouse. This is a mouse that we occluded, took out a portion of the femoral artery, and you can see the collateral arteries form. Here on the other leg, we didn't take out a piece of the femoral, and you don't see the collateral arteries.
Paula, can you please use the mouse so the people in Harlingen can see? They can't see.
Oh, Harlingen, how you doing? I was down there about a week or two ago. Okay, we can do this. Maybe. All right, there. That's where we took out the femoral, and there you can see the collateral arteries form. And this is where the femoral artery. The mouse doesn't cooperate so well. You can see the femoral artery that's intact. So this happens in humans, it happens in mice, it happens in rabbits, it happens in pigs, it happens in the heart, it happens everywhere. It is a mechanism that has been preserved through many, many species. So we started doing that in mice, and we were interested in how macrophages actually form collateral arteries. But what we started to notice is that the muscles below the knee, when we did this, basically died and became necrotic and then regenerated. And that was skeletal muscle regeneration. And I'd never really thought about skeletal muscle regeneration, but why should a self-respecting vascular surgeon study skeletal muscle regeneration? Well, it is a tissue that regenerates throughout the lifetime of a patient. and it has an easily accessible progenitor cell population. In other words, everyone here in their muscle has satellite cells, which are myogenic progenitor cells that when the tissue is injured, they proliferate, differentiate, and they form muscle, which is unlike heart and a lot of other types of tissue where their progenitor cell population isn't so well formed. And young patients need soft tissue coverage, especially our veterans coming back from Iraq and Afghanistan. There are a lot of extremity injuries. I can tell you here in San Antonio, the trauma service, we have a lot of degloving injuries. I have on multiple occasions come in late at night, reestablish blood flow. I have a palpable pulse in the foot or the arm, and the muscle all dies because muscle is the tissue that is the most sensitive to ischemia. And so while your bone and your skin may survive, the muscle's dead, and we end up cutting off the leg. So it's important. And we have patients that are essentially young. So if we think about where the vast majority of our regenerative medicine dollars have gone, they've gone to brain, spinal cord, and heart. Those are three tissues that certainly deserve a lot of study, but they're also three tissues that don't regenerate when they're injured. Doesn't matter if you're young, doesn't matter if you're old. And we're also looking with brain and heart at patients who are older, who have multiple comorbidities, and don't regenerate as well as young patients. So we've kind of taken the hardest thing and said that's what we're going to shoot for. It's like taking a first-year general surgery resident and saying your first case is a Whipple instead of doing a hernia or some skin closure. So to me, it seems like we should focus on tissues that naturally regenerate and try to come up with strategies there, then translate that to older patients, and then translate that to tissues that don't regenerate. So muscle regeneration has three main components. There's angiogenesis, or basically capillary formation. Satellite cells are those myogenic progenitor cells. And bone marrow-derived cells, which for our purposes can be stem cells that come from the bone marrow and travel to the injured tissue. But we have been much more interested in the macrophage and other inflammatory cells. So our lab has been very focused on MCP1, which is monocyte chemotactic protein 1. It's a pro-inflammatory chemokine, and it attracts and activates monocytes. The receptor for MCP1 is CCR2. So MCP1 comes and binds to CCR2 and causes a reaction within the cell. But CCR2 is the receptor for more than just MCP1. It also is the receptor for MCP3 and MCP5 in mice. So we hypothesized that impairments in muscle regeneration that we had seen in our hind limb ischemia model in CCR2 knockout in MCP1 mice resulted from a decrease in macrophage recruitment. Now, we had done a whole series of experiments with hind limb ischemia models, and there was impaired muscle regeneration. But we couldn't really define the collateral artery formation because that's very difficult in a little mouse. So we never really knew if the skeletal muscle defect was a primary defect because they just didn't regenerate well, or if it was a secondary defect because there was a more prolonged and profound ischemia because of lack of collateral artery formation. So we had to take our model to a different one where we didn't have hind limb ischemia to confound the results. So what we did is a cardiotoxin model, which is essentially you inject this toxin into the muscle. It causes necrosis, and the muscle regenerates. And this is what normal skeletal muscle looks like. This is a cross-section, and the nuclei are peripherally located, which is one of the beautiful things about skeletal muscle. An injured muscle cell will have the nucleus in the center. So we tell which areas were injured and which areas were not. This is 24 hours or 1 day after putting in cardiotoxin. And what you can see is a total disruption of the normal architecture of the skeletal muscle. And all of the mice look about the same at this point in time. This is our wild-type mouse. There's a lot of necrotic tissue. There's a lot of inflammation. That's what those little purple dots are. Remember from your histology, inflammation comes in at 24 hours. It's predominantly neutrophil at this point in time. And that's what you see in all of these. Lots of necrosis and lots of neutrophils. and you really can't tell the difference between our wild-type mice, our MCP1 knockout mice, and our CCR2 knockout mice at this time point. So these mice are genetically identical, except for the MCP1 knockout mice do not have MCP1, which is the chemokine, and the CCR2 knockout mice do not have the receptor for the chemokine. At day 3, we start to see a change. In the wild-type mouse, you see a very large infiltrate of these mononuclear cells, and these, for the most part, are macrophages. In the MCP1 knockout mouse, you can still see a lot of necrotic tissue, and you see some mononuclear infiltrate, but not nearly as much as in the wild-type mouse. And in the CCR2 knockout mouse, it's even worse from a perspective of fewer mononuclear cells. So there is a big macrophage recruitment defect. And we can tell that using immunohistochemistry and localizing an antigen called F480, which is present on macrophages. This is a wild-type mouse. So all of these brown cells have F480. And then there are certain cells like this one that are negative for F480, but positive for a different antigen, which is MyoD. MyoD is a transcription factor that commits the myogenic progenitor cell towards a differentiation path to muscle. So we have myoblasts present, and we have mostly macrophages, and probably a lot of other cell populations. So we can take the muscle, grind it up, use flow cytometry to actually quantitate the numbers of cells that we have. And this is an experiment using our 3 different types of mice, looking at this over time, and what you can see is that at baseline, in our wild-type mouse, which is shown in blue, there's very few macrophages, which is what you would expect. At day 1, they increase, they peak at day 3 and start to come down by day 7, and by day 14, they're back to baseline levels, and that's what the asterisk shows, is that there's a significant elevation above baseline. The red are our CCR2 knockout mice. And what you see is that there's very few macrophages present in them. By day 7, they're very similar to the other 2 mouse strains, but we never saw that big increase in macrophage like we saw in the wild-type mice. And then the middle one, the yellow, are the MCP1 knockout mice. And what they have is an intermediate phenotype in that while they recruit a lot more macrophages than the CCR2 knockout mice, that's the yellow versus the red, they certainly don't recruit nearly as many macrophages as the wild-type mice. So how would we predict that would show up in our skeletal muscle regeneration if macrophages mattered? Well, this is what the tissue looks like. So at day 7, after injury in a wild-type mouse, we have nice, round, skeletal muscle myofibers. And like I said, they have centrally located nuclei. And so really the difference between this and a mature muscle fiber is that the location of the nucleus is in the center rather than peripheral, and it's a lot smaller, and it will grow over time. In contrast, the MCP1 knockout mice have a lot of necrotic tissue. They have some small myoblasts that are growing into cells, but not nearly as many. And our CCR2 knockout mice have even more necrosis and even smaller fibers. And what you can see here, if I can get the mouse to work, this is actually a cell that will be positive for MyoD. Linda McManus in my lab is a collaborator in histology. She calls those the donuts. And so that is a myoblast trying to regenerate a skeletal muscle kind of in a sea of garbage because the macrophage didn't come and clean up the necrotic tissue. By day 14, the wild-type mouse doesn't look very much different other than that the size of the fibers have increased. The MCP1 knockout mouse by this time has cleared all of its necrotic tissue, but it has much smaller fibers than the wild type. And the CCR2 knockout mouse, even at day 14, still has residual necrosis. So we can measure this. We can measure the average cross-sectional area of our regenerated fibers. And at baseline, essentially, all of these fibers are very similar in size with our wild type, our MCP1, and our CCR2 knockout. If we look at the wild type, the fiber size by day 7 is smaller, but it basically increases, so by day 28, it's similar to baseline. our MCP1 knockout mice with their intermediate phenotype of recruiting macrophages have an intermediate phenotype when it comes to muscle regeneration, in that they don't regenerate as well as a wild type, and they're still significantly smaller than baseline even at day 28. But our CCR2 knockout mouse, which had very severe impairments in macrophage recruitment, all the way over to day 28, is only about half the size of baseline. And we have actually tried to take this out even further, and we're currently looking at 4 months as a time point to see if the CCR2 knockout mouse ever really comes back to baseline fiber size. So we can conclude from that is that CCR2 knockout mice have impaired muscle regeneration, increased adipocytes, which I didn't show you that data, but they do, and delayed angiogenesis, which is also another feature of this model. The MCP1 knockout mice with their intermediate phenotype, however, have intermediate phenotype with muscle regeneration and adipocytes. However, their capillary formation is very similar to a wild-type mouse. Now, all of these are published in a paper by Dr. Martinez. And, yeah, there he is again, Sirius Carlo. But this paper is kind of remarkable because this one spanned a very large number of residents that was in our lab. So that's another opportunity that you have if you come here. You can come to my lab, you can come to Ken Hargrave's lab, who's in the dental school, you can go to Joel Baseman's lab, who looks at mycoplasma pneumonia. We have and Dr. Swaka's lab, who does burn injury. We have, if you want to hold a pipette, we have a lot of collaborations and established labs for you to get involved into a project. And so this paper is very special and near and dear to my heart because it also has Oscar Ochoa, who was the first actually surgery resident that I brought in my lab, and Oscar actually worked out all the techniques for measuring cross-sectional area, fiber size, and adipocyte formation. So the area is there. Oscar was probably on about 5 papers because we were using his technique, and he was doing the data for a lot of different people. And of course, he had his own couple first author papers. Jason Wells was another surgery resident, and so once Carlo left the lab and the paper came back needing extra work, we had Jason and also Matt McHale in the lab. Where's McHale? Hey, McHale. Nope, not here. Uh-oh, mark him hasn't. Oh, he's in trauma. Okay, well, I guess we'll let that ride. So all of these gentlemen are on this paper. So it's kind of a motley crew, but here they are. Now, Dr. McHale also went on. So here we have a set of observations about muscle regeneration, about macrophages. We have a system that is set up and designed to be able to distinguish phenotypes in a measurable way. So we in medicine talk about phenotypes, but you have to, in science, be able to measure that so that if you affect the system, how do you know you've made a change? So Matt McHale wondered about how does gender, sex, male versus female, affect skeletal muscle regeneration? Well, so just to summarize his paper very quickly, these are males and these are females. And what we can notice here is that there's actually a fair amount of necrotic tissue at day 5 in a male, but not so much in a female. So females clear their necrotic tissue better than a male. So, yay for the girls, right? Now, here's the part that I feel is very unfair and I'm not happy about. The males, however, have very little fat in their regenerated muscle, and the females have lots of fat. And this is an oil red O stain, which basically picks up a liquid, so the red are the adipocytes. So, like I said, we clear the mice, at least female mice, clear their necrotic tissue faster, but end up with more fat in their skeletal muscle. So again, I don't think life is very fair. But the main conclusions of Dr. McHale's paper were that there was increased adipocyte accumulation in females versus males. And actually, he did a lot of work with ovarectomy and also castration in males. And what he found is that the intact females had more fat than if you remove the ovaries. And in males, if you did a castration, then the males who were castrated had more fat than the intact males. So the accumulation of fat appeared to be dependent upon sex specific hormones. And so he did a whole series of experiments, or he did oophorectomies on the female mice, and he replaced either progesterone or estrogen in either a physiologic fashion, so kind of normal levels, or in a superphysiologic. And so what he found, because the idea is estrogen is supposed to be beneficial for wound healing, the idea would be is if we have a trauma patient come in or some other patient, should we be giving them estrogen? Maybe if it's a woman or even if it's a man, could we improve a male's healing if we gave them estrogen? And what he found from his female mice is that basically the estrogen, if it was replaced in our oophorectomized mice, is they had decreased adipocyte accumulation. So basically the absence of estrogen in those females caused more adipocytes to accumulate, but also estrogen with the progesterone caused it to accumulate. And that, however, the superphysiologic levels of estrogen led to a decrease in fibrocytes, so it actually impaired muscle regeneration. So there's Matt again. And then this is Anna Schlechter-Salinas. And she was a medical student who worked with us in a summer research program, and she did a lot of the quantitation of the female mice. So she is also a co-author on this paper. So we have in the lab the whole gamut of volunteers, which are undergraduates and graduate students from other places. We have medical students who do summer research programs. I have 3 coming into my lab this summer. We have postdocs who are MDs. We have postdocs who are PhDs. And we also have another postdoc in our lab who is interested in the role of sex and age in muscle regeneration. And she's looking at muscle regeneration, adipocyte accumulation in young, middle, and old mice. And some of these mice are over 2 years old, which that's very old for a mouse. And we're looking at differences in males and females, and we're looking at the effect of MCP1 and CCR2 on this process. And that's Heather Hancock. So one of the things that the MCP1 and the CCR2 knockout mice led us to ask about is if the CCR2 knockout mouse has a macrophage recruitment defect, can we take this CCR2 mouse, give it back macrophages, and can we reverse the tissue regeneration defect? And so what we did is we isolated monocytes from the bone marrow of a wild-type mouse that carries a green fluorescent protein, a GFP marker. So we can trace these cells throughout the body of whatever mouse we give them to that doesn't have GFP. And we tried various delivery routes, intramuscular and IV injection of monocytes into the CCR2 knockout mouse, and then we measured the muscle regeneration. So here's some pretty pictures with our GFP, and so what we used as a control is just the bone marrow cells from these GFP-positive mice. Now, the monocytes in the bone marrow are about 10% of the cells, so the vast majority of the bone marrow cells that we injected were not monocytes, unless we specifically enhanced them for monocytes. And what you can see are the green areas right here, and this red asterisk actually follows on to this. And this is at day 7, and you can see that there's still a lot of necrosis, and you can see all the GFP-positive cells there, but it really didn't help the regeneration. For the monocytes, however, that we enriched, once again, there's still a lot of green cells, so those came from the bone marrow that we injected into these mice, and you can see that there's actually some small fibers that are being regenerated. Unfortunately, however, we couldn't get these cells to survive. And so while we could then sacrifice the mouse and look for the numbers of GFP-positive cells in the muscle, we certainly didn't have a large number. So we really didn't reverse the macrophage recruitment defect. Well, why not? Well, when we injected these into the tail vein, so an IV injection, most of them went to the spleen. And that's actually been published that perhaps bone marrow cells go to the spleen, sit in the spleen for a while, and then when there's actually an injury, the biggest recruitment comes from the spleen. And so what we found is that a lot of our GFP-positive cells were actually in the splenic red pulp. So it begs the question, how are children similar to monocytes and macrophages? And I could actually kind of say, how are residents and medical students sometimes similar to monocytes and macrophages? Well, they don't always go where you want them to go. And they don't always do what you want them to do. So clearly, we didn't understand our monocytes and macrophages because, I was looking at through if we can just get them where they need to go, they'll do what they need to do. And that brought us to the whole idea of macrophage activation and polarization states. So not all macrophages are created equally. They're different. And so this has been done predominantly in cell culture dishes, where essentially they put on one cytokine versus another cytokine, and they look at the cytokine profiles and what happens to these cells. So there are M1, which are the classical pro-inflammatory macrophage that get recruited with injury or infection. There's the M2As, which are usually considered to be stimulated by IL-4. And an M2A is actually a tissue-building type of a macrophage. They help in angiogenesis. They help in collagen formation. And then M2B is thought to be a macrophage that works with in more of an infectious process and not so much in regeneration per se. And then M2Cs are our regulatory macrophages. They're the ones who then say, okay, the tissue is being regenerated. We need to clear out the inflammation, because acute inflammation follows a certain cascade of events, and if that cascade of events is disrupted, that's when we have chronic inflammation. And so the regulatory macrophage is the one that's able to clear the inflammation and say everything is fine. Well, I have 3 children, and I have all 3 of these phenotypes. So this is Paul. He's my pro-inflammatory child. He likes the military. He likes destroying things. He's talking about which academy he wants to go to, and he's the first in. So I'll tell you, if there's a disaster, Paul is there, or probably creating it, perhaps. This is his twin brother, Patrick. He's my M2A macrophage. He's always trying to build the bridges that Paul then destroys, and always trying to make things smooth. And then my daughter, Anya, is my M2C. She's my regulatory macrophage. She has no problem telling her brothers exactly what they're doing wrong and how they can improve their lives if they only listen to her. So if we think about macrophage polarization states, this could be a great explanation about why our brilliant experiment with the CCR2 knockout mice failed, because we didn't have the right type of monocyte or macrophage. So Hanzhou Wang, and I don't have his picture, he's a PhD in our lab, is working on defining the time course and markers of macrophage polarization states. And he's also looking at how will muscle regeneration be affected by removing macrophages at very specific times. So we have these very special mice that we can give diphtheria toxin to, and they will, and the diphtheria toxin will essentially cause the macrophages to die. And so we can, depending on when we give the diphtheria toxin, ablate macrophages at very specific time points and then determine how that affected muscle regeneration. So the DTM is a mutant we use as a control. We gave it at minus 12 hours, at day 0, at day 1, at day 2, and day 4 to try to look to see when is it important to have the macrophage present. So this is the control right here in the white, and this is what is normally happening. So if we give the diphtheria toxin in the early time, either minus 12 hours to day 2, what we find is there's a lot of residual necrosis, so the macrophage doesn't come in and clean out the necrotic tissue. But if we give it at day 4, the necrotic tissue is removed. If we look at the cross-sectional area of our regenerated fibers, they actually regenerate relatively well if we give if we have in the normal mouse, or even at day 4. But as we delay the timing of giving the diphtheria toxin to day 1, we have the smallest cross-sectional area in our fibers. And then this is the percent fat. So the earlier we give the diphtheria toxin, the more fat we see in the tissue. And so Hanzhou has actually done a lot of work on this, and we're writing a paper up for Journal of Immunology now. So just to highlight one last project, just to see that there's a full breadth of things and a lot of different things you can look at, is that we've also become very interested in microRNA, and we have a VA Merit Review grant that studies this. And so microRNAs bind to RNA and cause them not to be translated into protein. So all of those Westerns and Northerns and that everything did and said, oh, the mRNA is up, we must have more protein, isn't always correct. because microRNAs can bind to those targets and make it so that you can have all the mRNA you want, but you won't get protein. And so we have been very interested in microRNAs because you can use them therapeutically. What happens to SICU players who sit in the unit for a while? Well, they lose muscle mass. Could we figure out which microRNAs we could give the patient, give them a weekly mRNA, a microRNA cocktail, and preserve their muscle mass, so that when they finally got out of the unit, they wouldn't have the months and months of rehab to try to recover? How can we use microRNAs to change chronic inflammation into acute inflammation and let it go through the process so that we resolve our chronic inflammation? And so David Melton is an MD PhD student, and he has a grant from the NIH to study exactly this, a training grant. And so he's one of our graduate students in the lab as well. So who really does the work in the lab? So this is my very serious lab crew that's working very hard here, as you can see. And we do have fun. And in fact, several years ago, the lab softball team basically was my lab. And Linda McManus is a collaborator who has worked very closely with us, and we also have lots of collaborators. So I'll just show you a few of the collaborators, and basically you always want to thank the granting agencies that give you the money. But now I would like to change gears and talk about healthcare, because once again, we're talking about constant change. And so we have what people believe is a relatively broken healthcare system in this country. I mean, there's wonderful things about it, there's good things about it, but it's not integrated. We talk about electronic medical records, but they don't talk to each other, they aren't doctor-friendly, they aren't patient-friendly. So how do we come across and how do we deal with this? So the Institute of Medicine has priority areas for healthcare quality improvement. And you can see them listed there: patient and family engagement, population health, safety, care coordination, palliative care, overuse, and access. And for the students sitting in Harlingen, access will be no mystery to you, because South Texas and along the Texas-Mexico border has very large problems with access to health care, disparities. It's a Hispanic population that's basically poverty-stricken and also has very low rates of insurance. And the health system infrastructure capabilities of here and everywhere else has issues. So Texas especially is in the lowest quartile for the number of measures in the top 10%. So the Institute of Medicine has these metrics, and they measure states and areas based on these metrics, and Texas is in the lowest top 10 percentile. So, and the core measures, Hispanics compared to other ethnic groups, compared to Caucasians, Asian, African Americans, Hispanics are the ethnicity that receives essentially the poorest level of care. And poor people, so a low socioeconomic class, which shouldn't surprise us, also gets the poorest level of care in this country. So we have a lot of work to do. The lower Rio Grande Valley, which is what we're talking about in Harlingen and along the Texas-Mexico border, has huge healthcare problems. They have an obese or overweight population. 80% of the adults are either obese or overweight, and 50% of the adolescents. So we can forecast the future that this problem is only going to get worse if left on its own. And there are many, many conditions related to obesity, of which, of course, one of the most important is diabetes. And 49% of adults have impaired glucose metabolism, and 40% of adults also have evidence of liver injury by looking at liver enzymes. And in the lower Rio Grande Valley, there's an increased incidence of liver cancer among Hispanic males compared to Caucasian and also compared to other areas of Texas. So what is the economic impact of all of this? Well, we've estimated that there's $227 million lost work days from diabetes, and that costs $227 million a year. That there's $675 million per year in diabetes care, that $725 million a year to treat obesity, and that the cost of diabetes and obesity care is essentially 12% of their annual income, because two of the counties down there are the two poorest counties in the country. All right? So their annual income is in like $24,000 range. But that's what the average family earns. So despite these huge disease burdens, the health insurance rates, only 25% of the people there are insured and 75% are uninsured. And insured patients compared to uninsured patients essentially get similar rates of treatment for acute care. I mean, you think about it. If you're having a heart attack, a gallbladder attack, you're going to go to the emergency room whether you have insurance or not. But what patients who aren't insured don't get is chronic care. They aren't diagnosed with diabetes and they aren't taken care of for it. So basically, you have insurance, you're more likely to be diagnosed for chronic diseases, you're more likely to be treated for chronic diseases. And so chronic conditions are not being treated in the uninsured. So the healthcare law, assuming it stands, most of these patients will be insured in 2014. And there's not just going to be a flux of doctors who go down there. There's not going to be a lot of change, I think, between now and 2014. So how can we bring care to the South Texas border without moving part of our physicians down there? So we can use telemedicine. And that's one of the initiatives that the Health Science Center is now looking into. So blindness from diabetic retinopathy is actually preventable. If you screen, you treat, you can prevent vision loss and blindness. It's almost 100% preventable. And the cost of blindness is huge. However, in the federal qualified health centers that actually the medical students rotate, so Clinica Harlingen is a federally qualified health center, they have a very poor screening rate for diabetic retinopathy. And so through the dean's office, through my role as a vice dean for clinical and translational research, we just put in a Center for Medicare and Medicaid Services grant for about $4 million over a three-year period of time to use telemedicine to screen for diabetic retinopathy in 3 federally qualified health centers and to use local ophthalmologists for the treatment once we have a patient that has a positive screen. Now, this is a grant that has 6 institutions, 3 federally qualified health centers. It has the University of Texas Health Science Center. I'm the PI. This is Kundan Nagi. He's an ophthalmologist who will be helping us coordinate and read the scans and coordinate the Department of Ophthalmology and helping with this effort. We have Sue Fisherhoek, who is at the UT School of Public Health in Brownsville. She will help coordinate the effort, the data management, setting the protocols in the 3 federally qualified health centers. And we have Dana Forgione, who is a professor in the business school at UTSA, and he will help us economically model this program, understand the cost savings, and then the whole idea of these grants is to talk to CMS to say, maybe you should change the way we are paying. Maybe we should be focusing more on paying for prevention and screening and catching diseases early rather than treating them after they're already either vision loss or much further down the line requiring a vitrectomy, say, rather than just a laser treatment. So it all sounds like this was a very well planned out career, right? That I knew every step that I was going, and I knew I was going to be a vice dean someday. I had no idea. So I have a few confessions. So number one, I became involved in research in my undergraduate because I thought it would look good on my CV, and I thought it would get me into medical school. And I bet if everyone was honest here, there's probably some of you in the audience that you probably would say the same thing. Number two, I hated immunology in medical school. I hated immunology. Now I spend a lot of my time thinking about macrophages. I know, be careful what you hate. It will come back to get you. And number three is I continue to do research in medical school to obtain a good residency. All right? And so a lot of you are thinking that same thing. And so John Story, the Purdue, where I did my undergraduate, just loves the fact that I spend a lot of my time doing research. He feels like he seduced me to the dark side of the force here, so that I spend a lot of time doing research. He is actually very happy about that. So what I hope I've shown you is that there's been a lot of change in my career, and there will be even more change in yours. So instead of being afraid of change, I want you to embrace constant change and to look for the opportunities associated with that change, because ultimately it is our goal to make things better, and you can't make things better if you don't change them. I think there are many challenges facing the U.S. healthcare system, and I think that you don't have to hold a pipette to do research. You can run a clinical trial, you can talk about health policy, you can take big databases and understand how patients are being treated, what diagnosis codes are happening. There are multiple ways of doing research. So I think there is a huge power of asking questions, and I can't imagine there aren't interesting questions that each and every one of you have that can improve the care of our patients. And I want you to embrace the power that you have to achieve excellence, because you have made it this far. You have made it through medical school, and now you're looking for a residency, and the residents who are here, you have become residents, and you need to think about what your next step in your career is going to be and who will mentor you through that. You don't want to discover the wheel. You want someone to teach you how that wheel was made so that you can add to that knowledge base. Thank you.